Right. Good morning, good afternoon, good evening, wherever you are, and welcome to this IA 2030 WHO and TechNet 21 webinar series on why gender matters for immunization. This is our third session, and today we'll focus on gender responsive actions for the health workforce. You can listen to this presentation in French. To do so, please select the globe at the bottom of your Zoom window and choose the desired language. If you struggle to find it, please do let me know in the chat area. I'm going to say that just once in French for our francophone listeners. Vous pouvez écouter cette présentation en français et il vous suffit de cliquer sur le bouton interprétation en bas de votre fenêtre Zoom et sélectionner français. If you have any trouble, any technical issue, please drop me a message in the chat box, and I will do my best to help you to solve your technical issue. Talking about the chat box, you can already introduce yourselves, and I see that some are already doing it. Tell us where you're from, and yeah, you can tell us your name. We'd be very happy to know who's with us today. You can also use the Q&A box. So next to the chat box button, there's a Q&A box, and you can ask your questions at any point during the presentation. The presenters will answer those questions at the end of the session, perhaps the last 20 or 15 minutes before the end of the session. So don't hesitate to ask your questions at any point in the Q&A box. Finally, this session is, as per usual, recorded. We'll share with you the links to the video as well as the slides. We hope you'll enjoy this session. And for now, I'll give the floor to Stephanie.
Thank you, Alex, and welcome everybody to our third webinar in this webinar series. As Alex mentioned, this is our third in the series, and today we'll be focusing on gender responsive actions for the health workforce. But just a little bit of a background for those who are joining us for the first time today. This is a webinar series that we are running based on the guidance document that was jointly developed by WHO, UNICEF, and Gavi last year on why gender matters for immunization. And every week in this webinar series, we do a little bit of a deeper dive into one of the recommended gender transformative actions that are covered in this guide. And so for all of you that have been joining us this whole time, you'll know that you received the links and the recordings to this afterwards, but all of the sessions and previous recordings are available also on our TechNet page dedicated to gender and immunization. And so we'll share the link to that in the chat. Of course, it'll also be available at the end of this presentation. And so if you missed any of the previous webinars, you can go and review the recordings there. And also do please share around to your network for anyone else who's interested in this topic, but has not been able to join us on any of the webinars yet. So just because I want to make sure we have enough time for all of the rich discussions today and Q&A at the end, I'm going to just jump right ahead. So as I said, today we're talking about implementing gender responsive actions for the health workforce. We have three presentations today, three different speakers. I'm very happy to welcome Michelle McIsaac, who is an economist and lead for the gender equality, human rights, and equity within the health workforce department at WHO. We also have Julianne Barungi, who's a senior social behavior change manager in the polio program at UNICEF in the National Emergency Operations Centers from Pakistan. And we also have Laurence Koja, who is another technical officer within the health workforce department at WHO. So with that, I'm going to hand it over to Michelle, our first speaker today, to take us through the introduction to this topic. Over to you, Michelle.
Hi, colleagues. Hi, everyone. Welcome. So it's my pleasure to give a brief overview of two spaces. So the first is what we call the Gender Responsive Assessment Scale here at WHO. And the Gender Responsive Assessment Scale is a tool that WHO has in order to help us to self-assess, essentially, our work to see where it falls on the spectrum of gender responsiveness. So there are several categories in which we have gender unequal, which is policies or practices that perpetuate or reinforce existing inequalities. Then there's gender blind, which is a category that just ignores essentially any of the differences between genders that might exist. So it's completely ignoring any of the gender dynamics. And then on the spectrum of towards gender responsive, we have those that are gender sensitive. So these are policies and practices that are aware of the norms and relations between genders, but they're not necessarily addressing the core drivers of inequalities that we see. And then on the really gender responsive side, we have gender specific. So these are ones that are specifically targeting women or men, challenging their gender roles and norms. And you'll see an example a little bit later on from Laurence, which has a policy which was intentionally gender specific, and even moving towards this area of gender transformative. So this is one that addresses the root causes of inequalities between genders and is really there to challenge these social norms and promote gender equality. Next slide, please. So I oversee an area of work at WHO in the Health Workforce Department, where we're looking at gender dynamics in the health and care sector. And the health and care sector is a very unique sector when you're looking at labor markets worldwide, because it is a sector that's dominated by women. So women have a very high participation rate in the health and care sector. On average, when we look at 189 countries across the world, what we see is that of all of these health workers that we can look at and count who are working in the health and care sector, 67% of those workers are women. So it's what we would call a very feminized sector. So women tend to participate more highly in health and care sector than they do in the average in an economy. So women's labor force participation rate is usually in the kind of 40% mark. So this is a very high participation sector for women. But what we know is averages tend to hide a lot of nuance and differences, not just among countries, where we have some countries where 90% of health workers are men, and some countries where 90% of health workers are women. So there's lots of variation among countries, but also what's hidden in an average is the dynamics within the sector. So there are two kinds of dynamics in the sector, which we call occupational segregation. One of those dynamics is that women tend to be clustered into certain occupations in health and care and men into others. So this is that midwives, for example, on average globally are over 90% women, and nurses are 89% women. And then we have categories like doctors, which tend to be more dominated by men, or CEOs, even more dominated by men across the sector. So this is what we call horizontal occupational segregation by gender. So although 67% of health and care workers are women, they tend to be clustered in the lower paid, lower status roles across the sector. And then within, there's another kind of occupational segregation. This is what we call vertical. So that means even within the occupation, women tend to be clustered in the lower status or lower paid portions of a particular occupation, and men tend to have more of the leadership roles. So women are underrepresented at institutional levels, at local levels, at national levels, and at global levels when it comes to leadership. And we know that about 24% of ministers of health across the world are women. So even though it is a sector that's predominantly women who are delivering it, it's tending to be led by men. The other kind of gap that we see in the health and care sector is one that is concerning pay. So what we can see when we look at the data and we compare the health and care sector to other sectors is that on average, if we look at like for like, so similar education levels, similar what we call labor market attributes, education, time spent, etc. We control for all of this. What we find is the health and care sector as a whole tends to receive lower pay than other economic sectors that are less feminized. And we see this sometimes with sectors that tend to have more women or are more feminized. These sectors tend to be paid lower than those that are dominated by men. And then when we look in this sector, which is on average underpaid, women in the sector are actually facing a very large gender pay gap compared to men in the sector. So women on average are earning 24% less than men. And this number, 24%, is when we control for education, we control for occupational category, we control for if you're working in the public or private sector, and we try and control for everything we can, we still see a very large gender pay gap. The third gap that we see is that women tend to be in certain kinds of positions in the health and care sector, and those positions that they're in often are those who have more demanding or more precarious working conditions. So women are more likely to be in part-time roles. Women are less likely to have the Social Security benefits that come with full-time roles often. They tend to be at the lower end of the pay distribution, to be in more precarious roles. So those that are what we would consider less decent work, informal jobs, etc. And then within that, there are safety concerns across the sector because a lot of these jobs are very patient-facing jobs, or they're outside in the communities, and they hold within certain kinds of risks. And some of these risks are gender-based risks. So there is prevalence of gender-based violence and harassment across the sector that we need to address. Next slide. So when we're talking about what we can actually do to implement gender responsive actions across the health and care workforce, we've done quite a bit of work in this area to look what the evidence base is, what is being done, what's effective, what works. And the first thing that we see is that we really need to ensure that we're collecting the data. So in a lot of areas, we don't actually have the gender disaggregated and occupation disaggregated data with sufficient frequency to really understand what is happening. So gender pay gaps, for example, is an area where you need to have both the occupation and lots of the attributes of the health workers along with their pay and their gender to be able to do this analysis. This kind of data we don't have for every single country. And we really need to be pushing so that we can look at this. And then when you do get the data, to collect it with enough frequency that we can monitor over time differences in working conditions, differences in pay, differences in different attributes as well. The second is that we really need to ensure that all health and care jobs are safe and decent work. So that would be to address the poor working conditions that many of these health and care workers are facing, making sure that health workplaces are safe places, that they're free from sexual harassment and violence. For example, by ratifying ILO Convention 190, which is the labor code for addressing violence and harassment in the workplace, which has a big focus on gender-based violence and harassment in the workplace, ensuring that at an institutional level that you have confidential feedbacks and complaint mechanisms if you are having any violence or harassment by coworkers or by patients as well. And then under this safe and decent work, it's really important that we expand formal employment. And this is particularly in countries where informality is a significant feature in the workforce. And what I mean by informality is the ILO definition of what informality is, which is that it's not covered by social protection. So that is that these jobs don't have the normal kinds of social protections that go with work. And we really need to address and ensure that jobs in health and care are really following the principles of decent work and that they're attractive jobs so that we can address some of the shortages that we see globally for health and care workforce. And then the next is that we need to ensure that the pay is adequate and equal. So what we mean by adequate and equal means that the health sector tends to have pay that's a little bit lower than other sectors, even if we're looking at the same, attributes as education and time and effort maybe for the jobs. So we need to make sure that the health and care sector's pay is at level with the rest of the economy, so it continues to be an attractive sector, and that within there, men and women are paid equally for work of equal effort or equal value. For this, we really think that pay transparency and legal frameworks to establish binding mechanisms against pay discrimination are effective and important and have been proven to help us to close gender pay gaps. So these are really important both across the entire economy, but also in the health and care sector as well. Equal pay audits is something that we've seen to be very effective, and some of the countries who have the smallest gender pay gaps have implemented equal pay audits, and this can be very helpful. I'm sitting in a country, Switzerland, right now, who has this as part of a legally necessary part of the law that is here for equal pay audits. The next is that we need to ensure that we're leveling the playing field between women and men. And by this, we need to really promote equal opportunities. So this is both to address that horizontal occupational segregation by gender, so that women, can have opportunities in all of the different kinds of occupations in health and care, that they're not segregated just in occupations that are considered very highly feminized, that men as well have opportunities across all of the different occupations in health and care, and then also within occupations that the leadership and access to the leadership is available to everybody. Next slide. So here we are just sharing a little bit of the information that we have from the health and care workforce, both in the realm of strategic documents. So these are documents at WHO that have gone through the World Health Assembly. So they're resolutions and related to resolutions. So we have the global strategy on human resources for health, which calls for the adoption of gender sensitive employment policies and gender mainstreaming. And then we take that further with the High Level Commission, which is the UN High Level Commission on Health, Employment, and Economic Growth, which really tries to talk about the health and care sector, not just as a sector that addresses women's health, but as one that is catalytic for women's economic empowerment. So a very good labor sector for women, to get them into the labor market. And then we have the Working for Health Action Plan. So this is one of WHO's mechanisms for operationalizing policies and planning at country levels and support. And we had an action plan 2017 to 2021. And just in 2022, we had the new action plan, which is adopted at the World Health Assembly. And for this, we had gender consultations feeding into the Working for Health Action Plan. So we brought across gender experts to talk about what needed to be a part of this action plan. And through this, we were really trying to apply a gender lens in all policies and plannings across countries to help us to build more gender equitable workforces. The key for the Working for Health is that it's multi-sectoral. So it's working with the ministries of health, the ministries of labor, the ministries of gender, the ministries of education. And when you see Laurent's presentation, you see why this is very important for us. And then we have a series of technical resources, both for helping us to collate disaggregated data, which is the National Health Workforce Accounts and Indicators, and then the use of this data a few years later in our first gender analysis in this area. And then we have a gender equity hub as part of the Global Health Workforce Network, who has created 2 documents, both looking at the state of play, where the major gender gaps are, and particularly one about closing gender leadership gaps. Then we have also some analysis tools, which have a module on gender analysis within it, and the pay report with ILO that we launched last year. And the last resource here that might be useful is the Global Health and Care Worker Compact, which is a resource that links to global mechanisms for decent and safe work and health and care. And with that, it's my pleasure to pass over to the next colleague who will be presenting on female frontline health workers. Over to you, Julianne.
Sorry, how are you? Can everybody hear me?
Yes, we can hear you.
Yes, loud and clear.
Okay, thank you very much. I'm going to make a presentation. I'm going to make a presentation on Frontline Worker Initiative that was conducted in Pakistan. And this was in line with some of the challenges that we're having in the program, not knowing what the challenges for the frontline workers were. And we wanted to look away how we could co-design together with them some of the solutions to address the challenges that they were facing. And we're doing this together with the polio partners, who are Bill and Melinda Gates, CDC, UNICEF, WHO, and the government of Pakistan. So the background to this study was that we needed to reduce the pockets of missed children in the terms of polio, and the refusals who were a key problem to achieving the eradication of polio within the program. We also wanted to see that the frontline workers, who are our valuable assets, are heard and are able to be reached, because these polio workers go house to house, go door to door in every single household in Pakistan to vaccinate the children. But they have so many challenges that come up to them. And then there was no systematic way of hearing from them and knowing what they do, what they are facing, and how we can support them. We used to get dribbles of feedback, and these were not enough for us to have a strategy to address some of these challenges. So we decided to have co-design workshops where we bring the frontline workers together, and then we decide to identify the problems and address them together and ask them to come up with the solutions on their own. So that was the main purpose of us having this initiative, where we're trying to co-design with the frontline workers. We selected the 25 very high-risk districts. This is the districts where we have high numbers of the polio affected children, or high environmental samples, or positive environmental samples where we know that the virus is circulating within the environment. And this whole initiative was coordinated under the National Emergency Operations Center, which coordinates the polio response and working with the gender working group. Next slide, please. Next slide. Next slide. Can you hear me?
Yes, we can hear you. Okay.
Okay. So what was the methodology that we used to make sure that we get a representative sample of the issues that we would like to address as a program? We conducted structured and randomized phone surveys, because this is the best way we'll be able to reach the different people. And we already knew from the telephone service providers that at least 90% of the people in Pakistan have mobile phones, and they didn't need any expensive phones. They just needed simple button phone to be able to respond to these questions. So we conducted these randomized structured surveys with male and female and listened to understand their experiences. And we conducted this through the third party. The questions that we received, we reviewed and finalized and looked at what are the barriers that they were facing. What were the barriers for the frontline workers to reach the missed children, those children who were not being vaccinated? What were the barriers that they faced during the campaigns? And what are the issues that are affecting their motivation and safety? So the questions covered these areas in the survey. So on finalizing the survey, we also did an analysis of the results to try and curate the issues discovered and see how can we address them and how can we co-design with the frontline workers. One of the key learnings in this study was that it was not us, the technical people, who were coming up with the solutions. We wanted the frontline workers themselves to come up with, to identify the challenges and identify the solutions. And we would then implement together, and we would agree on who does what, including the community as the stakeholders. So we worked in 25 very high districts. It took us about 2 quarters to finalize the study. And we had a third-party vendor to help us conduct this study. Next slide, please. So how was this different from the other programs that were ongoing? Well, of course, there is engagement with frontline workers, but it was not systematic. So this particular co-design initiative was systematic across the 25 very high districts. We identified the ladies, we asked them the questions through the survey, and we got the frontline workers' perspectives anonymously through the phone survey. And on completion of the survey, as I mentioned, we looked at the different questions and we did the consultations across all the different districts and province and national level and community level. Our lowest level of implementation is the UC level, which is where the households are. So we looked at the different frontline workers at these levels to be able to give us these responses. So we also designed workshops. The workshops were also designed in an enabling way. We made sure that the workshops were not crowded by many of the facilitators. We made sure that we only came in and we did not speak during the workshops, meaning that we let the frontline workers air their views, share their viewpoints, be able to share their challenges without interrupting, without questioning. It was only the third-party vendor who was the facilitator who was doing the talking, and the talking was trying to get out as much information from the frontline workers as possible. So whoever attended the workshop was an observer from us, the technical people. It was only the frontline workers allowed to speak during the workshops, and the facilitators to engage and try to get information that was required and try to validate the information that was got from the surveys, and then also try to get solutions for the challenges that had been expressed. Next slide, please. So we want to give at least a sneak peek into what we did. One of the barriers to reaching the households, one of the barriers was the frontline workers, at least 1 in 10 said they were not able to reach the households to vaccinate the children. Remember, for the polio vaccination, we go house to house and we vaccinate every child under 2 or under 5 as desired by the campaign. So, and when we asked them, why are you not able to reach these houses? In some areas, they reported different reasons why they were not able to reach these areas. In different districts, for example, Hyderabad, Karachi, as you can see from the slides, there were different proportions of frontline workers who were not able to reach the houses. And the reasons why they were not able to reach that came out strongly were lack of transport, which was 68%, unaffordability of transport, inability to locate the target household, and so on, as you see in the last graph on my right. So transport came out as a major challenge for some of these frontline workers. We were providing funding for them, but we realized it was not adequate, though we thought that this would be enough to cover them for transport as well. So we came to realize that this was a challenge that was stopping them from reaching the household. Next slide, please. So in these workshops, after getting the challenges that the frontline workers were facing, as I said, we conducted these workshops, which were 2-day workshops with a third-party vendor that was facilitating the session. Now, remembering that, as I mentioned, we as technical people came in as observers, and we tried to limit the number of people going in there because they would scare the frontline workers and not be able to express themselves. We limited it to women as well, because in Pakistan, it's culturally sensitive. We had the women alone. At one point, at the end, I think we also had a session for the men to listen from them, but these were initially designed only for women to get to understand why they're having challenges as they implement. And we know that in the Pakistan culture, it's not easy, it's not acceptable for a man to access a house. It's only women who can go into the house and vaccinate. So the men are not allowed to get into the house, so it's not culturally appropriate. So that is why we try to get frontline workers who are female to reach these households. And we know that 83% of the frontline workers are actually female. And in some areas, we really struggle to get female workers registered. So our workshops, we're looking at, as I said, the barriers for reaching the target population, and what are the barriers at the point of sale, and what are the barriers in experience and motivation for these frontline workers. Next slide, please. So in the final session, we also looked not only at the barriers to reaching the household and vaccinating. We also know that we are working towards the eradication of polio in Pakistan. So one of the things we wanted to look at was what will happen beyond polio. So we wanted to hear from the frontline workers themselves. We've got about 300,000 frontline workers working for polio, and Pakistan is a vast country. So we wanted to know, after the polio, what next? Because these women have been empowered. These women have come out of the household. These women are doing quite a lot. They've been exposed. They have been trained. So after the polio is gone, we do not want to drop them just off like that. But again, we do not want to think for them. So we also decided to say, let's talk to the frontline workers. What do they think they can do beyond the polio program? So again, we laid a structured process to identify future opportunities of interest, where they would want to be engaged and where we could support them. So we identified interest both within and outside of the health sector. Some of the women told us they wanted to do hairdressing. Some of them wanted to do tailoring. Some of them wanted to have computer lessons. So we gathered all these interests that they have for us as an organization to see how best we can track through the next step of these ladies. So the ideas will inform our planning process, which is being led by the government of Pakistan under the NEOC, to see how we can have a transition for these ladies to the vocational training opportunities and other areas that they have identified. Next slide, please. Just to mention that this initiative was really appreciated and strongly supported across the whole of government, right from the national level to the community level. We got the provinces, we got the national coordinators, we got the ministers. They all took part, and it was the first time that there was a structured listening to women expressing their needs, expressing their wants, and also enabling them to co-design solutions right now. At the moment, we have already responded to the solutions that they identified. We had the low-hanging fruits. There were some things that are simple that we could be able to address quickly. They wanted the certificates of recognition. They wanted identity cards. Those we were able to address. Issues like transport, issues like umbrellas, like water bottles, like boots that require funding. We're working towards those big ticket items, and we shall also be able to address them together with the provinces and the communities at large. But we are really, we saw a very strong partnership and response across the whole of the country. Next slide, please. I'm coming to the end. Yes, so I will not go through this again. Just to give you the overview as a summary, we started by listening and co-designing to the frontline workers. Now we are at the second stage where we are reviewing and implementing the solutions that have been co-designed with the frontline workers. And of the third stage, we are looking at how we can work with a partner to help form a transition plan for the frontline workers, taking into consideration the areas that they identified where they would be of interest to support transition from polio to other programs. And I think I have a last slide. Yes, so thank you very much. This is the last slide, and would be happy to address any questions that they have. Thank you very much. Bye. Over to the next presenter.
Thank you so much, Julianne. Laurence, are you able to unmute?
Sure.
Okay, go ahead.
Good afternoon, everyone.
Good afternoon, everyone. This presentation will take place in French. So I hope you can all hear me. So this afternoon, I'd like to present a study case in Niger on gender and health workforce. So Michelle was very clear in our presentation, what are the main challenges for health workers? And today, I'm actually going to present some concrete actions here So for this presentation, it was of course prepared by us people in Niger and not by WHO. It's just that the people here weren't here available. That's why I am actually presenting these slides to you. Next, please. For this presentation, I will first cover gender policy in Niger. So this is really to explain how gender is considered and also what are the means that the country is implementing to achieve their targets. Then I will cover the key findings. I do apologize, I can't see my screen very well. Just give me 1 second. So the key findings for gender and health workforce. And we will discuss here, of course, some of the challenges. And after that, I will also discuss solutions, recommendations implemented to achieve the targets. And to conclude, we'll see how these solutions, how do they contribute to Immunization Agenda 2030 in Niger? Next slide. So Niger, as you know, is a country facing a lot of challenges, like many other countries in the area. There is a lot of insecurity related to what's happening in the neighboring countries. There is also limited access to health services and some other cultural barriers, which have a direct impact on gender. So with this situation, here, the country of Niger decided to implement a gender policy in order to try to improve the situation, focusing on gender, to build with all stakeholders, to create a society free from discrimination, and where men and women, girls and boys, have the same opportunities to contribute to the development of the country, but also enjoy access to employment and also enjoy all the benefits. So this is a policy that was adopted in 2017. It's a 10-year policy, and that will contribute to the Sustainable Development Goals. Next. So the strategy implemented here concretely on the ground to achieve here this gender policy. The first pillar, first strategy, is to improve the social, cultural environment to overcome this barrier, to ensure that men and women have the same opportunity to contribute to the growth of the country. Second strategy is to ensure that the rights of women and girls are respected and that we fight against gender-based violence. And the third strategy or pillar is about the economic development, empowerment, taking into account, of course, migration, environment, disaster management. And the last strategy or pillar is a better coordination, strengthening institutional mechanisms to make sure the government can reach their objectives. So it's, as you can see, a very broad policy. But let's now refocus on healthcare here and the health workforce. Next slide. So there is a plan, the social development plan, that was implemented to make sure that the human capital is taken into account, but also trying to here fill in the gap. Here, the gender gap, talk about health, talk about nutrition, but also ensure that the population has access to drinking water, hygiene, and sanitation, and making sure that the social protection is improved. So as you can see here, it is a very comprehensive development plan to make sure that the gender policy can be implemented. Now on human resources, next slide. So if you look at this graph, based on different studies conducted in Niger, we looked at the labor market. The difference here based on gender and how this can actually impact here the availability of the workforce. So what you can see here is that women have less access to training, medical training. And Michelle actually explained that really well earlier. One of the issues that we have is really access to some medical training, such as here, that's what we can see in Niger. This is a reality. And of course, in our last result, we also noticed that this is a trend that has not improved over time, unfortunately. So women still and remain here in a more difficult situation regarding to access to training. Next slide. So we know that, as Michelle said, women represent the majority of a health workforce, 59% actually here in Niger for the public sector and 49% here in the private sector. So not taking into account the gender question or the gender lens, when actually women represent the majority of the health workforce, it would be in not useful at all. So next slide. So we know that women represent 66% of public nurses. But we've also noticed that the majority of women actually work as nurses. And when it's a kind of a higher positions, it's mainly men. So we can see here that this is a clear trend. And we can see that because women have less access to medical training, men have more access, therefore, and therefore the girls or women actually focus on nursing. Next. So that means other issues too. And that's what I'm trying here to illustrate. This is really about the inequality in distribution in the country. What you can see here on this graph is like doctors and midwives are kind of located in some areas. For nurses, who are mainly women, we can see that it's a little more balanced, but 10% of the total population is using 24% of nurses, 36% of midwives, and 43% of physicians. And why? Because they are located in urban areas. So the rural areas where the majority of the population lives in Niger, they have less access to healthcare professionals. Next. So what's the problem then in rural areas? So based on this study of the labor market in rural areas, we looked at, again, the gender and the different jobs available. We can see that there is unequal opportunities when it comes to access to training. We know, for example, that there's very few schools, medical schools, outside of urban areas. So that's our first barrier. But also, the population in rural areas have less resources to finance here, of course, this training. Because if they have to choose between the boy and the girl, they will finance the studies of the boy rather than the girl. And that training is not free. So the population here cannot pay for both. Therefore, we know that here for the rural areas, it really has a very strong impact. So another important aspect is the strong reluctance of women, of girls, to work in rural areas, to go further away from their families. So, for example, when the Ministry of Health would like to send them, for example, working in rural areas, they do not want to go first, because to actually go and work in a rural area, they need the authorization of their husband or father, but either way, they're not interested because they want to stay close to their families. So therefore, the needs of the rural population are here not taken into account. And when it comes to career, continuous training, we also know that, unfortunately, as we know, we need even like community health workers. So based on everything I've just presented to you now, what has the government done? So first, the government has integrated these aspects with an integration based on a strategy, an approach to recruit and train and improve also here healthcare workers here quality of life in rural areas. So what does that mean concretely? That means for boys and girls living in rural areas, they will be able to have a better access to healthcare training. Actually, not only healthcare training, but also generally here on social services, agriculture, to be able here to study, to acquire the knowledge and know-how, to be able then to go back to stay in the rural areas and promote the development of these rural areas. It's absolutely essential. And we also know that this strategy makes it possible to really improve the quality of services, but also to promote here community health. And that's what we were saying as well with Pakistan. So highlighting how important it is for girls to get access to the proper training, here professional training, even if that is high up, such as the university, and then access to decent jobs. And this is done through a very favorable policies for these young people working and living in rural areas. So this strategy has started. And that means that at structural level, you need roads. So we've discussed actually transportation rate in Pakistan. Well, the same thing here. You absolutely need roads, you need transport. Here, we have to also think about water, sanitation, hygiene. The schools, public and private schools, need to be accredited, so that means certified. And the World Bank financed a loan to implement all these infrastructure in rural areas, so that it's then possible here to implement all these initiatives. So once we've put that into place, there will also be a cooperation to support, of course, providing a high quality of care and services. So there's also here the World Bank, the Islamic Bank, the Islamic Fund of Development. And it's true that when we talk about the vaccines, immunization, that will be a way to, of course, comply with a vaccination here calendar, but also schedule, but also answering to the needs of women, children, and adolescents, and ensure that community here health workers can have a better access to children, to women on immunization. So what we would like to promote is a better work together, better cooperation. That should be a model for girls growing up, so that they can stay in school. And of course, the fact that they will have opportunities that will be possible for them. So this program, through governance, will also allow women working here to be able to improve services and to promote, of course, promotion here of women. So let me show you here and that's what I wanted to say about this study case in Niger. Thank you very much for your attention.
Thank you so much, Laurence. And sorry, I think we missed advancing through the last few slides, but it was very clear in your presentation, taking us through the implementation pieces that the government is putting in place to operationalize these recommendations. So thank you so much. It was a really interesting presentation. And thank you so much to Julianne and Michelle as well. We only have a few more minutes left. I know that there are already some questions in the chat. And Julianne has been diligently responding to the ones that were specifically related to her presentation on the Pakistan program. So I'm just going to look now to see if there's any new ones for Laurence, or in the meantime, if Julianne, maybe there's one that you can answer live, just so that everybody has the benefit of hearing. So I see one just on some of the extra things that were raised for, sorry, it just disappeared because I think you just answered it while I was looking at this. Some of the additional points that were raised on the discussions around the gender pay gap, or other things that came up in the focus group discussions with the frontline health workers in Pakistan. And if you want to answer that one live, just so that everyone can hear it.
Okay, yes, thank you very much. I was just trying to answer the question in the chat. Some of the issues that came up, of course, our ladies do face some issues of harassment, either from the community or some are from the supervisors in the work. So they were asking for us to have a mechanism in place where we could be able to address some of these challenges that they were facing. So we have a gender consultant on board right now who's helping us to come up with a policy on gender and a reporting mechanism and a redressal mechanism for our frontline workers. Remember, I told you we have about 300,000 frontline workers that we are dealing with. So there are quite a number of issues to deal with. They also wanted to have some areas for rest during the campaign week where they can use a bathroom, where they can have some sitting. Remember, you cannot put the men and the women together. So they wanted to have some separate places where they can be able to have some rest, some changing, some breastfeeding, some of them who have children. So yes, we did have some specific requests that were gender specific. And one of the main ways of addressing this, and we're trying to really expedite it, is to really have this redressal mechanism that they asked for in areas where they're having harassment, maybe from supervisors. And they also asked they wanted more female supervisors. They didn't want to have a lot of male supervisors, which is a challenge because even recruiting women and getting them on board in Pakistan continues to be a big challenge for us. But we're trying to incentivize women who will come out to help with the supervision, especially in the endemic areas where we're trying to address the issues of the virus still being rampant. Thank you.
Thank you so much, Julianne. And I think we're running to the end of our time, but just to address one or two of the other questions or comments, somebody said that the HR and gender issues go beyond vaccination. They're problems known for a long time. And I think this is true for a lot of things, not just related to the human resources issue, but a lot of the gender related barriers to immunization that we've been discussing on the other webinars and that are covered in this guide are usually beyond just the immunization program. They're either systemic issues that are embedded in sociocultural dynamics, or like this comment, they're more broadly to the health system beyond immunization. So absolutely, of course, there are linkages beyond immunization, but this just emphasizes the importance of working with our partners outside the immunization space, trying to leverage collaborations and synergies with other ministries or other units that are working on these issues, bringing those stakeholders into the conversations around program planning for immunization, and really considering this with a broader health systems lens. So absolutely, thank you for making that point. Just want to add again, here's the link to where all the recordings and materials can be found. So please do go visit there. And of course, reach out on TechNet or anywhere else if there are additional points that you want to discuss about today's webinar or questions that didn't quite get answered. We are happy to continue this dialogue. And just to say that our next webinar is actually next week. So we've been doing it every other week up until now, but in order to accelerate through July and be able to finish in time for everyone to go on summer holiday, we're going to do these for the next few weeks in a row. So our next webinar is next Thursday, and the topic is community engagement and social mobilization with a gender responsive lens. So please do join us. Again, share this link widely, encourage your network to register. And thank you again to our TechNet organizers for the logistics, to all our presenters today, and also another thank you to Michaela Manna, who is coordinating this webinar series with us at WHO. So thanks everyone, have a great afternoon and see you again next week. Alex, anything else?
No, that's fine. Thank you very much. We can close this webinar. Thank you. Bye, everyone.